All right. Well, thank you to MDF for having me, and thank you all for joining here in person or online. Let's get started. I will be talking about myotonic dystrophy type 1 or DM1. I will be talking about genetics, about symptoms, and a little bit about how to manage symptoms. So first of all, how many people live with myotonic dystrophy type 1 or DM1? Sorry. Oh, okay. Previously, we thought that it's about 1 in 8,000 people in the U.S. that have myotonic dystrophy. But a recent study, we learned that it's actually a lot more people that have myotonic dystrophy, and about 1 in 2,100 people carry the genetic mutation that causes DM1. That is about 140,000 just in the U.S. And that means that there are people with DM1 in the community that are not diagnosed, underrecognized, that may or may not have symptoms and do not know why they're having symptoms. And what we'll be talking about is what symptoms do people with DM1 experience? Why does DM1 cause so many different symptoms, and how can those symptoms be managed? So let's get started with what symptoms do people experience. And I just want to start with a disclosure, because myotonic dystrophy type 1 is extremely variable. In fact, it's one of the most variable diseases in medicine. And that means that people can develop their first symptom anytime throughout a lifetime. Some people develop their first symptom at birth. Some people in the first decade, second decade, third decade, fourth decade, and some people develop their first symptom at older age in their seventh decade. So that's a huge variability in disease onset and severity. In addition, myotonic dystrophy is also very variable in terms of what type of symptoms people develop. Most conspicuously, the muscle is involved. You see on the left-hand side, muscle weakness and myotonia, for example, and we'll talk about that. But in variable ways, people may have other multisystemic symptoms, such as involving the GI system, cognition, sleepiness. Some people have diabetes, others do not. Some people have weakness of the breathing muscles, eye involvement with cataracts, and that can vary. So just bear in mind as we go through these slides that some of these symptoms may apply to you and some may not, because the disease is so variable. So now let's move to why does DM1 cause so many different symptoms, and why does it infect so many different organ systems? It's called muscular dystrophy, but it's not just a muscle disease. In fact, it can affect all types of tissue. And to answer that question, why that is, we have to make it a little bit more complicated and go into the genetics. And so the following slides will be a little harder, but we'll get through it. And I do want to go through them because when we are in an exciting time in myotonic dystrophy, as you heard from multiple people, because we're about to, or at least we believe that we have therapeutic strategies to treat myotonic dystrophy, and not just the symptoms, but the root cause of the disease at the genetic level. And that's why it's important to understand a little bit more about the genetics and about the mechanism of the disease, because as more treatment trials are coming your way, it's important to understand where does it target, where, at what level is the root cause of the disease being addressed. And so let's start here with the genetics. Again, it's a genetic disease, and here you see the chromosomes that everyone inherits, every one of us. And we have 22 pairs. One chromosome is inherited by mom, one chromosome is inherited by dad. And myotonic dystrophy is located on chromosome 19, and the gene is called the MPK gene, and that sits on chromosome 19. And you may see here that DM1 is right there, the cause of DM1. And the type 2 myotonic dystrophy, which shares a lot of features of myotonic dystrophy, and there's a lot of commonalities, it is actually on a different gene, on a different chromosome. So there are genetically distinct diseases. They just share a lot of mechanistic and symptomatic features, but just that to understand that they're separate. So how is DM1 inherited? It's what we call autosomal dominant. That means that, as you can see here, there is an affected parent, and that affected parent has one copy of the myotonic dystrophy gene that is abnormal and one copy of the myotonic dystrophy gene that is normal. Now, the child of that person has a 50-50 chance of inheriting the abnormal copy of the myotonic dystrophy gene. So this individual here in green that is affected by myotonic dystrophy has a 50-50 chance of inheriting a myotonic dystrophy to a child. And that is like flipping a coin. And it is independent of how many family members already have myotonic dystrophy. So for example, if a couple has 3 children and 2 of them have myotonic dystrophy and 1 does not, based on genetic testing, if they have a 4th pregnancy, a 4th child, the chance is again 50-50 flipping a coin. And that's what we call autosomal dominant. So now let's zoom in a little bit on the chromosome, on the myotonic dystrophy gene called DMPK here in blue, and take a huge magnifying glass and focus in on the DNA. The DNA is made out of building blocks that we call nucleotides, and they come in a repetitive order. So here you see CTG, CTG, CTG. That's a repetitive code that we all carry nearby the DMPK gene. Everyone has that code. But what's different between people with and without myotonic dystrophy is that people without myotonic dystrophy usually have up to 37 of those repeats, of those CTG repeats. Now, in myotonic dystrophy, you have more than in blood cells, on the DNA in blood cells, people have more than 50 repeats of those CTG repeats. And I just spoke about how variable myotonic DM1 is clinically. It's also very variable genetically. So people can have in their blood cells more than 50. That's diagnostic of myotonic dystrophy. But people have a range of repeats. So the repeat length can vary from 50 to over 1,000. And why is this a problem if you have too many of those repeats on your DNA? At the DNA level, we'll have to move on to the RNA level. And just as a reminder, the DNA is kind of the template, the code that gives rise to all the proteins that we're made of. And so the DNA gets transcribed into RNA, which you see down in the blue box. And the problem is that this extra repeat is transcribed into extra too much RNA repeats, and they are just then CUG, CUG, CUG. And so there's too many of them. And so now you may ask, now, still, I don't know what's the problem if you have too much DNA on there. Well, if we zoom in really closely on muscle tissue, which you see on the left-hand side here, and we take a close look and do extra staining, what we can see is that extra RNA, those extra CUG, CUG, CUG repeats, they actually don't just float around in the cell, in the nucleus. No, they stick together. Because there's so many of them, they kind of build these clumps. We call them toxic clumps. And they clump together. And when you stain for them, they pop up like this. You see that little red spot. That's the CUG expanded repeat. Now, why is it troublesome to have these clumps? Because the clumps itself don't cause problems yet. But when we move on here, there are important RNA binding proteins, important proteins that float around in the nuclei of our cells. And those important proteins have really important jobs to do, and I will comment on what they do in a second. But the issue is in DM1 is that these important RNA binding proteins, they get stuck in those clumps. They get trapped in those clumps. And because they're trapped in there, they can't function properly anymore. And so what does these RNA binding proteins look like usually? Well, in a healthy cell, they would just float around in the nucleus and be available to do their job. But in myotonic dystrophy or DM1, you see down there that they're stuck in the nucleus and they lose function. Now, what do they usually do? Oh, could you give me 1 second? So to prove here visually that they actually are stuck exactly in those clumps, when you merge those images, so staining for the repeats, staining for the important proteins, the repeats are in red, the proteins are in green. And when you merge those pictures, here's the proof, the clumps actually really trap those green proteins. Now, what do these proteins usually do? Why is it a problem that they do not function properly anymore? Well, they usually edit and splice RNAs from numerous other genes. So there are other genes that have nothing to do with the myotonic dystrophy gene, but they are dependent on those RNA binding proteins to edit them and make them pretty and cut them so that they properly can be used as a template to form proteins that make up our body. And so to give you an example what that actually means, there is, for example, a chloride channel RNA from a chloride channel gene, and that RNA needs those proteins to be edited. It's not happening properly, and that's why myotonia occurs. Then there's a calcium channel RNA. It's not properly edited anymore because the proteins are stuck there, and so weakness occurs. And then there is an insulin receptor RNA that's not properly spliced and edited anymore because the proteins aren't available. They're stuck. That causes diabetes. Similarly, a sodium channel RNA isn't properly spliced anymore. That causes irregular heartbeat, and so on and so on. That is the cause why myotonic dystrophy causes so many different problems, not just in the muscle, but in other organ systems. I mentioned earlier that DM1 can cause symptoms at any age from birth to the 6th decade. And so we are interested to understand, why does DM1 affect people in so different ways, and specifically even within one family? And to as a disclosure, we don't have the answers, but we have some ideas. And I would like to introduce two concepts of why that is. And the concepts are called anticipation and somatic instability. And both relate to the problem that this expanded repeat, the CTG repeat, is just incredibly unstable. What does that mean? Let me see. Okay, what does that mean? Well, if the repeat, the genetic mutation, is inherited from a parent to a child, it has a tendency to grow bigger in size, and to actually not just grow bigger a little bit, but to have huge jumps. So in the germline, the repeat is unstable and it has a tendency to grow. And what does that result in? Specifically, when the disease is inherited through a mom, there is a chance that this jump is particularly big. And so what you see here, there's grandmother who is mildly affected by myotonic dystrophy type 1, and then her daughter is a little bit more affected, and then the child has the congenital form of myotonic dystrophy. And throughout those generations, from generation to generation, the repeat grew in size and the disease became more severe. And that's what's called anticipation. Now, the other concept is that the repeat isn't just unstable from generation to generation, but that it also is unstable in certain tissues, body tissues, throughout a person's life. So what that means is that the repeat grows in size in some body tissues throughout life, and it grows in different tissues at different rates. So for example, a lot of you may have had their blood tested for the mutation, for the DM1 mutation. In fact, in blood cells, the repeat doesn't grow a lot. It's fairly stable. That may not come as a surprise to you because there isn't really myotonic dystrophy symptoms related to blood cells. There isn't really a problem with blood cells. However, in the tissues depicted down here on the bottom, the muscle tissue, the heart, and the brain in some people, the repeats grow a lot in size throughout a lifetime. And we think that that is triggering off the disease or worsening the disease throughout a lifetime. Now, let's shift gears from that and talk about a little bit how symptoms can be managed. I would like to just say up front that I learn a lot from you, and I learn a lot from my patients I see in clinic. And what I always hear is that it's living with a rare disease, even though I told you it's a common rare disease. Finding a team of therapists and doctors familiar with the condition is hard. Depending on where you live in the United States, it's even harder. And so the alternative is to find a team of therapists or doctors that are willing to learn about it, which is the most important thing in general, because I still learn and I will learn moving forward. So it's extremely important that people are willing to learn from you and through care guidelines, because there are care guidelines that MDF put out, and that you can alert your doctors or your team to. And that also sometimes means have your doctor reach out to an expert, have a phone call, have them have a phone call, things like that. And if they're willing to do that, I think that's worth a lot. And so with that, I'll move on to some of the symptoms that you're well familiar with. But one of the symptoms that often is the first symptom reported by people with DM1 is the myotonia. And the myotonia is the delayed relaxation of the muscle. So making a tight fist and then opening it, it gets stuck. And I have a video here. I'm not sure I really need to show it because you probably all know, but I can't show it because I can't click on it. So we have to skip the video, but you know how that looks like. And I just wanted to, actually, this video demonstrates the warm-up phenomenon, which you are all familiar with. In the cold weather, it's worse. In the warm weather, it's better. And so the more you use your hands, the less pronounced the myotonia is, the delayed relaxation. So to the point that people tell me, well, I would try to get into my house in the winter. In the winter, it was snowy outside and I couldn't turn the doorknob because the hand was stuck. And usually that person is able to do it, but just in the cold weather, it was impossible, which can be quite difficult. So how we can actually treat myotonia with medications, and that these myotonia medications treat the symptom. So they relieve the symptoms. And choices are mexilotine and ranolazine. Important is when you bring that up to your doctor that they check an EKG first, because those are medications that can have an impact on the heart rhythm. And so you want to make sure that it's safe for you and your particular situation to be on those medications. But for some people, and I usually ask my patients, how much is myotonia an issue? Is it bothersome? And if it impacts work, for example, I have a patient who is a nurse in an emergency department. She has to do all these little caps and do IVs. And so that was really important that the myotonia was treated. Others may not feel that's a big issue in their activities. So it depends on the individual whether we treat or not. And then moving on to muscle weakness. So DM1 causes weakness preferentially in certain muscle groups. And those are depicted here in red, which are usually called distal, which means those muscles are a little bit further away from the trunk. So the hands, the forearms, and the lower leg. And then as the disease progresses, other muscle groups nearby, the hips and the shoulders can be affected too. A muscle that's often early on affected also is the neck flexors. So for example, lying in the bed and lifting the head from the bed can be difficult. Or for example, in the car and then or on the plane when there are turbulences, that can impact the stability of the head. Or I have a patient who went on a boat ride and it was hard because it was rocky and the neck, she had trouble stabilizing her neck. So that's the neck strength. Facial weakness can occur, as you know, the droopy eyelids can occur, and then weakness in facial muscles. And then importantly, there can be involvement of the breathing muscles, so the diaphragm and the expiratory breathing muscles. And we'll talk a little bit about that in just a second. Now, what to do about this? I really hope that this talk will be different in a couple of years, and I will be telling you different things, or someone else will be telling you different things, how to manage muscle weakness and what kind of treatments are available, because again, we are living in a time where we think that myotonic dystrophy will be therapeutically tractable soon, but at the moment, we don't have FDA-approved treatments to change muscle strength or the trajectory. So at the moment, what we encourage is don't become too sedentary. Physical activity, exercise. There are numerous papers out there demonstrating that moving is important. Moving exercise is safe, and keep what you have in terms of your muscle strength by being active. I do recognize that's a challenge, not just because, there's weakness. How do you exercise? And some people cannot do what they used to do, what they enjoyed doing because of weakness. And then there's sleepiness and apathy and things like that interfere with the ability to be active. But anything is better than nothing. And I usually have that conversation with all of my patients. It's important to come up with an individual strategy. So talk to your therapist about what's good for you. Also pick an activity that you're willing to continue doing that is somewhat fun, or incorporate it into a routine or regimen. If you watch a show regularly, maybe do it while you're doing something active, things like that. The other things that are important to address in the clinic is avoiding falls, because if you break a bone, that's a setback, and that makes you more sedentary and lose muscle strength and bulk. So we don't want that. So sometimes assistive devices are necessary. And I will go through some of the next slides, indicating what that can look like. So here you see a graph. This graph is made out of data from over 929 people with DM1. The National Registry housed in Rochester collects data and has collected data over the last 20 years from people with DM1 and through annual surveys. So every year there's a survey sent out and we ask people, are you using an ankle brace? Have you started using an ankle brace? Are you using a wheelchair? We ask about milestones of disease progression, basically. And all of these people fill it out, or a lot of these people fill it out and send it back. And we're extremely thankful, because that gives us an opportunity to learn from you how you experience the disease and when people actually need those assistive devices or use those assistive devices. So there's a lot of data, a lot of effort in just that one graph. On the x-axis, you see age. On the y-axis, you see the probability of using a certain device. So 0 on the bottom means no one is using an ankle brace. 1 on the top means everyone is using an ankle brace. And so as you can see, as people get older, the risk of needing an ankle brace increases. You also see that the solid line, and that's what I'm highlighting here, is DM1. And you see that not everyone is using an ankle brace throughout their lifetime, but some people are. And so at age 50, for example, it's about 15% that use an ankle brace. And the risk to use an ankle brace up at age 60 is about 25%. Similarly, when we look at walker use, utilizing that data, we see, again, that's the same graph, same, y-axis is the probability, the risk of needing a walker. On the x-axis is the age. So at age 50, the risk of needing a walker is about, again, 15%. And at age 60, it goes up to about 35% of needing a walker. Now, the last graph in that fashion is wheelchair use here. So, for example, the risk of needing a wheelchair for people with DM1 up to age 60 is about 20%. And that's what we learn from the registry. And that helps us when I have a new patient in the clinic. I understand that the answer, the disease is very variable. It's extremely variable, isn't always satisfying. And we're a little bit stuck with that. But this kind of data helps us give a ballpark of what the risks can look like. So now let's shift gears and talk about other symptoms. Heart disease. As I mentioned, you would think that muscle disease, heart muscle, the heart has muscle, it's probably the muscle. No, it actually isn't. Most commonly, DM1 affects not the muscle, but the electrical wiring in the heart. And that means the nerve goes to the heart and then travels through electrical wiring through the heart and then activates the heart muscle. And so that electrical wiring that transmit the signal for the heart is impacted. And so what can happen is that there's slowed transmission, or even the transmission is totally stopped. And so that is called different or varying degrees of heart block. what kind of symptoms do you have when you have heart block? You may have no symptoms. You can be what we call asymptomatic. People can have symptoms such as dizziness, or when there's irregular heart rhythm, heart, chest pain, palpitations, things like that. But again, it can be associated with no symptoms, or sometimes people have trouble when they sleep. And so there are no symptoms when you sleep. What is necessary is to have an EKG every year. No matter how old, everyone should have an EKG every year. And I have had the experience that people told me, yes, I went to see a primary care physician or even a cardiologist, and they told me my EKG is fine, and they said I don't have to come back. And that's not true. So you have to have an EKG every year, because if the EKG is fine, that's great. But it's possible that those conduction problems can occur later in life or throughout a lifetime. So it's important to keep monitoring that. And it's recommended that if you have symptoms, if the EKG is abnormal, or when you're on the older side, greater than 40, to consult a cardiologist. In general, bottom line, the threshold to see a cardiologist should be low. So an ultrasound of the heart is also recommended, but less frequent. So usually not every year unless it's indicated and your cardiologist recommends it. The treatment for these heart issues, the heart block, is pacemaker, and in rare instances, defibrillator is indicated. The pacemaker kind of picks up that work and then paces your heart if there is a problem with the transmission of the electrical signal. And in the registry, what we learned is that as people age, the risk of needing a pacemaker increases, and that's about 25% for people up to age 60, and then increases after that. So it's important so again, as you can see, not everyone needs a pacemaker, but a decent fraction of people do. And so it's important to keep monitoring. Now I will transition to something that's incredibly important, particularly in my experience in younger folks, excessive daytime sleepiness. Excessive daytime sleepiness means not just being tired, but either having a huge sleep requirement, sleeping hours and hours more than everyone else, or not feeling rested in the morning, or having to take naps during the day, or falling asleep in situations where other people may not fall asleep. And that does not refer to, after lunch, having had a big meal. No, it's more, in situations where it's really excessive. And I know from people that this, and some studies too, that this can be quite impactful on people's lives. I do appreciate and recognize that, specifically in younger folks in their 20s who are trying to have a job, have a career, go to school, or even in teenager years, and then had to stop their wishes and dreams because of excessive daytime sleepiness. And sometimes it occurs that at the time they didn't even have a diagnosis of myotonic dystrophy, and so it must be even more struggling if there is no real cause for that and no explanation. But excessive daytime sleepiness, when I talk about that in clinic, I usually try to highlight 3 possible causes in the setting of DM1. And one problem that can contribute to excessive daytime sleepiness is sleep apnea. Sleep apnea, central or obstructive. Now, let me say a couple words about that, because sleep apnea is well familiar in the community, right? A lot of people have sleep apnea in the community. And usually, risk factors for sleep apnea in the community is if they're overweight, short neck, things like that. But that's different in myotonic dystrophy. If you have weakness of these muscles here in the neck, and they relax in everyone when we sleep, and those weak muscles relax even a little more in patients with DM1, then sometimes it's hard for the air to go out and be expelled. So that can cause obstructive sleep apnea. Now, central sleep apnea refers to when the sleep center in the brain is not regulating the breathing properly. And that happens in DM1 as well, because DM1 can have effects on the brain and specifically the sleep centers. So sleep apnea is important to think about when someone has excessive daytime sleepiness. The other possible contributor is weak breathing muscles. And I'll just comment on that a little bit. So the weak breathing muscles, the diaphragm. And when we breathe in, the diaphragm moves down. When we breathe out, the diaphragm moves up. So when we sit, gravity helps us because it pulls down the diaphragm. Now, when we lie down flat in the bed, the diaphragm doesn't have help of the gravity anymore and has to work harder to go down and up for breathing in and breathing out. So oftentimes, when people have weakness of the diaphragm, because that is a muscle, it can cause problems first at night when asleep, because the diaphragm just gets tired of doing all this work. And so that can cause headaches in the morning, or being really groggy in the morning, or shortness of breath when lying flat. When these other muscles here are involved, also, it can be troublesome to cough or clear sputum. If people have frequent respiratory infections, it's also important to look for that. And I'll talk about how to assess the breathing muscles in just a second. But weak breathing muscles, if you don't breathe well at night, if the diaphragm has to work hard and is not breathing off the CO2 sufficiently at night, it causes you still sleep, but the sleep is not as restorative. And so people can be tired during the day. And then the last cause of contributor to excessive daytime sleepiness related to DM1 is just the effects of DM1 on the brain and sleep and the sleep centers. So there are people who have no sleep apnea and totally strong breathing muscles, but they are still sleepy during the day. And that is because there is just the DMPK gene is also causing these expanded repeats and the expanded RNA and those toxic clumps. They do occur in the brain as well. Not in everyone, but again, in some people. And so that by itself can cause the sleepiness. So some people have a combination of one cause, both, or three. It varies, but it's important in clinic to tease those out. And how do we tease those out? Well, we recommend spirometry. So where you take a little device and you breathe in real strong and you breathe out, and then it measures how much air fits into your lungs and how strong your muscles are in breathing in and breathing out. And we do that sitting and lying down. And most people that I see in clinic haven't had it lying down. And I just explained why we do that, the lying down test, because lying down, we take away gravity. And if there's a little bit of weakness of the diaphragm, we can pick it up when someone is doing the test lying down, because again, gravity doesn't help. And so that's what we recommend. For the sleep apnea, and the issues with breathing overnight, we recommend a sleep study, preferably inpatient. Your doctors may order a pulse oximeter, a little thing that you clip on your finger when you're at home at night. That is good for sleep apnea in the general population out there, but it's not as good for people with myotonic dystrophy because DM1 sleep issues are more complex. And so an inpatient study is really important. Now, why are we doing these things? And why is it important to tease those out? Well, because there is a treatment for the sleep apnea, and there's a treatment for the weak breathing muscles, and that involves non-invasive ventilation. So wearing a mask at night that helps your diaphragm breathe in and breathe out. Now, I do recognize it's hard to tolerate that sometimes. And I hear from my patients that have tried, and it's hard to tolerate, and some are unable to tolerate it. One thing I would like to mention, though, because I've heard so many different stories, sometimes it's worthwhile to keep trying for a little while. Try different masks. Make sure you have a provider who is willing to go that road down with you and not just say, oh, you didn't tolerate it, done. Okay, you didn't tolerate it, so there's nothing we can do. It's good if you have someone on your side who keeps working on this, because I have had patients who've tried for a little while and they actually were able to find a regimen, settings, a device. There are numerous devices out there, and there's new ones coming on the market all the time that were able to find the right match and make it work for them. And that's important. it may or may not make you feel better during the day, but treating it is important because it can have other impacts on health in general, if you don't breathe well overnight and if you have untreated sleep apnea. So it's important to pay attention to that. Now, if you have non-invasive ventilation and you still feel tired during the day, or you actually don't have sleep apnea and you don't have weak breathing muscles, but you're sleepy, then medications can help if they are safe in your situation, and those are stimulants. Now, how many people actually use those non-invasive ventilation, the mask, at night? When we look at the registry data, it was about 20% of people with DM1 using devices up to age 50. We are not asking who had it prescribed and wasn't able to tolerate. So that's actually the people able to use it. Now let's shift to GI symptoms. There is an extra talk on this, and I would recommend attending those GI talks because there aren't a lot of people out there in the community that are or GI physicians that are really familiar with DM1. It can be difficult. GI symptoms can affect the GI tract anywhere from the mouth, swallowing, all the way down to the sphincter. Symptoms can involve difficulty swallowing, abdominal pain, constipation, bloating, diarrhea, either or both or alternating. There is people with DM1 have gallstones and oftentimes have their gallbladder removed earlier than other people in general population. And so I do recognize GI symptoms can be incredibly disabling. You can go outside with hand weakness, but some of my patients cannot go outside if they have a bad day of GI symptoms. That can be really impactful on lives, and we recognize that. The good part is that GI symptoms are due to affected smooth muscle. So the muscle in our limbs and in our breathing muscles, that's skeletal muscle. And myotonic dystrophy also causes problems with smooth muscle. And the smooth muscle is, again, in the GI tract and some other organs, like the female organs as well. And so, again, I hope that this part of the talk will be different in a couple of years. We don't know for sure, but hopefully the smooth muscle will also be therapeutically tractable when we have therapies targeting the root cause of the disease. Now, how to monitor for these GI symptoms, again, it can be frustrating, but consult a GI specialist, and again, have a GI specialist that's willing to learn with you and go along that road with you, even though they might not be familiar with myotonic dystrophy at the beginning. Myotonic Dystrophy Foundation has put out care guidelines, and there's a long list of things in the care guidelines, also listed down here, some of them, what to try. And my experience is people always need to do trial and error because one regimen may not work for another person and the other way around. And some people have found even supplements and certain over-the-counter things that help them. And then also try to identify food triggers that make you feel worse. So again, recognizing they have a lot of impact. They can be difficult to treat. And the therapies that are listed down there, they're all non-specific. So we don't have a DM1 GI treatment. These treatments that are out there are really used for anyone who has these kind of GI symptoms for whatever cause. A word on anesthesia surgery. Just make sure your doctors know about it. There is, MDF has the anesthesia guidelines online that have been around for a long time, and it's just one sheet. So the short version. So just take that sheet with you, give it to your anesthesiologist, and make sure they're willing to look at it. And bottom line is that people with DM1 can be more sensitive to sedating medications, more sensitive to opioids, for example, that can worsen GI symptoms, of course, constipation, but they can also make people more groggy or affect the breathing. And then if you're in a cold OR, the myotonia can get worse. And then just make sure your heart is checked out before having a procedure. Generally speaking, I say it's good before having a surgery. It's good to have team of doctors that are willing to learn about myotonic dystrophy, but it's also good to know your breathing status. Do I have weakness of my breathing muscles or not? And what does my heart look like? What does my EKG look like? Those are the important aspects. A word on cancer, because there is an increased risk for cancer, including melanoma and some OB cancers, such as of the uterus, thyroid cancer, colon cancer. But I'm not here to, that shouldn't scare you, because the risk is, of course, when we look at this, if we looked at the cancer risk in the general population, you would see it go up with age, because there is just an increased risk of cancer for everyone. But when studies were done, it did show that there's a slight increase in DM1, and the mechanism, there are some hypotheses of why, but we don't know exactly why yet. But bottom line is that when we asked in the registry, for example, people, 24% of people, for example, reported up to age 60 that they had some type of cancer diagnosis in their lives. And what does it mean? No, you do not need scans from head to toe. What it means is you should follow with age-appropriate cancer screening. So basically, what everyone should be doing, I would just encourage you particularly to do, which means see a dermatologist every year. I do recommend that for everyone, but just see a dermatologist every year to make sure there aren't any suspicious moles or so. And then follow up with your OBGYN. And you can discuss a thyroid ultrasound with your doctor. The caveat is we don't know how to screen for thyroid cancer. There is no screening for thyroid cancer. The risk of having ultrasounds of the thyroid is that something is found, like an abnormality, and then you have a host of medical appointments and tests, and it may turn out to be nothing. And there's all that what's associated with it. That's the risk, basically. But that's something to discuss with your doctors, whether you should have, a thyroid ultrasound should be done. And then I do recommend, if you have it done every 3 years, and then you're good. I want to end, that was a lot. And again, a lot of symptoms, a lot of problems that can occur. But I want to end on this note, because I told you that it's not useless to go through these slides, because really, I hope that, and it's a disclosure that it's a hope, but I do strongly believe that we'll have a little bit of different talks in the next couple of years, and that the symptom management hopefully will morph into a different conversation about targeted treatments. That's what we envision for the future, and that's what we are all working towards too. And so what are the strategies? How do we want to tackle this? Not just treating symptoms, but really tackling the root cause. And so approaches that you will hear about are targeting the DNA itself, really going into the DNA and cutting out that gene or cutting out the repeats. That's difficult to do, and this is not coming to the clinic anytime soon because it's difficult to do, and it will take a little bit more work, but that's one approach. The other approach that is actively being tested and that you will hear about is tackling it at the RNA level. So not making permanent changes to your DNA, but really, for example, cleaning up those clumps out of the nuclei and releasing those proteins by cleaning out those clumps. And so that's what's being done right now and being tested in the research centers in people. Now, the last approach would be, for example, to not just clean out the clumps, but just releasing those proteins that are trapped in the clumps. Because if we release the proteins, then they can float around and edit and splice all these RNAs again, and hopefully reverse symptoms or improve or stabilize symptoms. And so releasing those proteins from the clumps is another approach that you may hear about in the future. And with that, I want to close and thank you for your attention and take questions.
You call the question. You pick up.
Oh, yeah.
I was wondering if they know why it's usually worse, quote unquote, worse when it's passed through the maternal line rather than the paternal line?
Yeah, so that's a great question. So the question is, why is it why is the jump in the repeats, right? Why is the growth of the repeat worse when it's from mom to a child rather than from a father to a child? So that's intergenerational jump. Why is it bigger? There are certain theories about that. We don't know definitively, but there might be some relationship to how the gene is methylated in that area, or how the repeat is stabilized in that area, but it's not definitive. I would also say, one thing I just noted I didn't mention, the sex of the child doesn't matter. So it's the maternal transmission, but it doesn't, which has a risk of, having that congenital form of myotonic dystrophy, but it doesn't matter whether the child is a boy or a girl. Does that make sense? Yeah. Okay. Oh, maybe this side. Yeah.
Yeah, I have a few questions. They're basically yes or no questions. Now, is the muscle weakness, is it wasting or just weakness?
It can be both. And so what happens is that there's weakness. Often, well, let me take a step back. So because it can affect people throughout a lifetime, right? So in the adult onset, so beyond age 10 usually, there's weakness, and then it can result in muscle wasting as well. Muscle wasting just means, the muscle shrinks and gets smaller. And what we don't know, though, and that happens in some people more than others. What we don't know, though, is that reversible or not, that we will learn in the future. Can it be that muscle that is shrunk and wasted, can that recover? Theoretically, I would say yes, but we will learn that in myotonic dystrophy.
And also, now I can't bend my fingers anymore. Is that arthritis, or is that part of myotonic dystrophy?
So I can't tell if you have arthritis. That's always, in general, anyone with DM1 can have other medical problems too, right? So sometimes I learn that some doctors, I have to, pay attention to not do that either. Just chalk up everything to myotonic dystrophy. No, it's important to really think about someone holistically and make sure other medical problems are being addressed and not everything is just, chalked up to myotonic dystrophy. But what you describe, the weakness of the fingers, that's very typical of myotonic dystrophy or DM1. And in fact, the finger flexors, these muscles, so when you make a fist, it's hard to make the fist all together. That's typical for myotonic dystrophy. And those muscles here are often affected first and early. So I would say it sounds like that's what's happening, but yeah.
Okay, then another question, kidney function. Does myotonia have anything to do with kidney function?
So good question. So to our knowledge, the kidney isn't really having trouble from myotonic dystrophy. Typically not. But the way we measure kidney function is by measuring creatine kinase, so an enzyme that comes from the muscle. So that can be low in myotonic dystrophy. And so the measurement of kidney function sometimes can be more difficult in myotonic dystrophy because the measurement is something that is related to muscle. But if someone comes to me and has kidney problems, I would look very broadly and not chalk it up to myotonic dystrophy.
And I wanted to say that aqua therapy really worked for me.
Yep.
So that's a good one. And I also wanted to know about, have you heard about crispy?
I'm sorry?
Crispy? It's
CRISPR. Yeah. So the hot words are always CRISPR, which is more of a methodology or method how to manipulate genes, and it's used widely. And then gene therapy. So gene therapy is usually reserved. That term is usually reserved for treatments that target directly the DNA on the DNA level, like cutting out things, replacing genes, things like that. We don't. The current methodologies that are being tested in clinical trials are not gene therapy, but I call them genetic therapy because they are targeting the RNA. So gene therapy may be something, we do think gene therapy will be something we'll learn about in the future in myotonic dystrophy, but it's not ready yet. It's not entering clinical trials in the near future. And near future, I mean, the next 1 or 2 years. That's my perspective on it. Yeah.
Excuse me.
Yep.
Given that there are a number of people who walk around with this disease without knowing it, I've always wondered, it's possible you could end up in a relationship with someone else with a disease. Neither of you would know it. And I wonder what the math of inheritance would be. And I wonder whether the betting would be that the symptoms would be different than if only one parent had it and you had an affected child.
Yeah, so there are reports. There are reports on having 2 abnormal copies of. That's what you're referring to, right? Chances are low, but can happen. And there are case reports of having 2 abnormal copies. And to our knowledge, it doesn't make a huge difference. But what I would say, though, to your point, there are people walking around and they can't do family planning because they don't know. I do think that specifically as therapies become available, it's extremely important to do better ascertainment of the genetic mutation in the general population. So to test more, to test broadly, to test more, not just because then people can maybe, if they want to, consider that in their family planning, but also if therapies are available, the question will be, when should we treat? If someone is midway through their disease course or early on, or even before someone develops symptoms. And that makes it extremely important to test early, yes.